Hemodynamics in prone position.
Thank you very much, Pedro. So good afternoon, everyone. I will talk about a little bit hemodynamics during prone position. My conflict of interest. Probably you are convinced that prone position is a common treatment in ARDS patients, especially in COVID-19 patients. In this study, a global unit study published some months ago, around 65-67% of COVID-19 patients were prone during their stay in the ICU. I will talk about some elements we are in this paper, which was published 2 days ago in Critical Care with Christopher Lai and Xavier Monet. And if you want to know more about my talk, you can look at this paper. So you can now finally leave the room. But I will try, nevertheless, to convince you that there are some hemodynamic effects. So I start from this prone position. And 3 events can occur during prone positioning, which can affect hemodynamics. First, increase in intra-abdominal pressure, increase in arterial oxygenation, and increased lung recruitment. Increase in intra-abdominal pressure, there are many papers showing that. This is one of them coming from our group with Christopher Lai. In patients who increase or not cardiac index, prone position increased intra-abdominal pressure, sometimes a lot, sometimes not, it depends. Arterial oxygenation, of course, this is one of the objectives of prone positioning, is to improve arterial oxygenation. And lung recruitment, this is another objective of prone positioning, is to recruit lungs. And we know that not all patients have recruited lungs. And in this paper by Martincourt and others, they show that in COVID-19 patients, there is a good correlation between the increase in compliance of the respiratory system from supine to prone and the air to eye ratio. Okay, these 3 events can have some hemodynamic consequences. Let's start by lung recruitment. You know that in the lungs, you have 2 categories of microvessels. You have extra-alveolar microvessels and intra-alveolar microvessels. When you increase lung, you have a compression of the intra-alveolar vessels, but a dilation of the extra-alveolar vessels. If I represent this on this graph, which is a classical graph with pulmonary vascular resistance on the y-axis, the lung volume on the x-axis from residual volume to total lung capacity, the resistance of the extra-alveolar vessels decreased from RV to TLC. But we also have intra-alveolar vessels, and the resistance of these vessels increased with lung volume. And the resultant effect is this kind of U-shaped curve, very classical curve. And the nadir of this curve, the minimal value of the resistance, are at the level of the RFRC. Knowing that, if you recruit lungs with prone position, for example, starting from a value of end expiratory lung volume which is below RFRC, you can improve and you can decrease the pulmonary vascular resistance. So lung recruitment is supposed to increase or to decrease pulmonary vascular resistance. And this is associated with a decrease in PVR due to the improvement of PaO2 by the decrease in hypoxic vasoconstriction. So you have 2 effects resulting in a beneficial effect on pulmonary vascular resistance. And with Mathieu Zosviak, Xavier Monet and others, we addressed the hemodynamic effects of prone positioning by using a Swingens catheter, and we observed that the gradient between the mean PAP and PAP decreased with prone position, and the pulmonary vascular resistance also decreased by 39%. It's not negligible. So now, at the opposite side, the venous side, we have, with prone position, an increase in the mean systemic pressure, which is due to the increase in abdominal pressure. In this study with Christopher Lai, we observe an increase in the mean systemic pressure, whatever the increase in cardiac output, in patients who increase or not cardiac output. Sometimes a huge increase in the systemic filling pressure, the mean systemic filling pressure. And normally, this results in an increase in the venous return pressure gradient, the difference between the mean systemic pressure and the CVP. And this is what we confirmed in this study. This gradient, this difference, increased with prone position in all the patients. But at the same time, as you know, the increase in abdominal pressure will increase the resistance to venous return. So there is a balance between both. And the resistance to venous return can increase a lot in patients who increase cardiac index as well as in patients who do not increase cardiac index with prone position. So if the increase in the venous return pressure gradient is higher than the increase in the resistance to venous return, this should result in increase in RV preload, in increase in central blood volume, and we know that increase in central blood volume also can decrease the pulmonary vascular resistance. Because when you increase central blood volume, you will increase the pulmonary venous pressure, and therefore you can decrease the extent of zone 2 conditions in the lungs, and you should decrease PVR, pulmonary vascular resistance. So again, you increase the extent of zone 3 by reducing the extent of zone 2, and you improve the pulmonary vascular resistance. And this should result in a decrease in the right ventricular afterload. And this decrease in RV afterload should result in a decrease in the RV-LV interdependence phenomenon. So in patients with dilated RV, this could be beneficial, and this could improve the LV preload by reducing the size of the right ventricle. In this paper I talked about already, we also used echocardiography, and we looked at the RV endoscopic area over LV endoscopic area ratio, which is a good marker of RV function, which decreased with prone position. And the LV eccentricity index, which is a marker of the septal shift, also improved with prone position. This should increase LV preload. At the same time, the improvement in RV preload should result in increase in RV output, and also the reduction in RV afterload, and this also should increase LV preload. So now it depends on the presence of preload responsiveness, preload reserve or not. If the left ventricle has some preload reserve, is preload responsive, you can improve cardiac output. If not, there is no change in cardiac output. Having said that, now we have to consider how to assess preload responsiveness. In this study with Mathieu Josviak, we looked at patients who increased cardiac index during prone position compared to supine, and patients who did not. And before proning the patient, we perform a passive leg raising before. And we observed that an increase in cardiac output by more than 8% during PLR can predict an increase in cardiac output by more than 15% during prone position compared to supine position. So this is a way to detect preload responsiveness, but before proning the patient. So now, I told you that sometimes, well, not sometimes, you could have an increase in the resistance to venous return higher than the increase in the venous return pressure gradient. In this case, you should have a decrease in venous return. So cardiac output will decrease. So we have different situations, variable effects of prone position on hemodynamics. And in this paper with Christopher Lai, we looked at all these behaviors. And of course, increasing abdominal pressure, mean systemic pressure, CVP, resistance to venous return. And of course, if you want to have an increase in cardiac output, you should be prone responsive. This is necessary. But sometimes cardiac output does not change or decrease, exceptionally decrease, but this is a possibility. This, of course, will happen in prone and responsive patients, but this could happen in prone responsive patients when the venous return, the resistance to venous return are high due to the increase in abdominal pressure. This is what we observed here, a huge increase in the resistance to venous return, in particular in that patient who decreased cardiac output. Look at the huge increase, more than 200% of the resistance to venous return. And this happens when intra-abdominal pressure increases a lot. So what is important is that there is no increase in cardiac output in case of prone unresponsiveness. This is physiology. And an increase in cardiac output in case of prone responsiveness if the increase in intra-abdominal pressure is not excessive. So it is important to monitor intra-abdominal pressure when you prone the patient. It is also important to assess prone responsiveness before prone position or better during prone position. It could be better. And in a recent paper with Ruishi and others in my unit, we tried to look at the reliability of the tidal volume challenge during prone position. You know, the tidal volume challenge consists in increasing tidal volume in patients who are ventilated with a low tidal volume, 6 ml per kilogram. You increase by 2 ml from 6 to 8, and you look at the change in pulse pressure variation. If pulse pressure variation increases a lot, more than 3.5% in the studies we did, probably the patient is prone responsive. But this was demonstrated for patients in supine position. And this paper addressed the question in patients during prone position. And we found that this tidal volume change works well also in these patients with an area under the ROC curve of 0.94, which is better than PPV alone. But note that PPV is not bad in this study. ARDS patients with COVID-19, not all patients had COVID-19. We included patients with COVID-19, patients with no COVID-19. Nevertheless, PPV in this study was good during prone position. The area under the ROC curve was 0.85, but it was better to have a tidal volume challenge to improve the results. So I encourage you to do this during prone position. So the take-home messages of my presentation is that in patients with ARDS under protective ventilation, prone positioning decreases RV afterload, which is beneficial in cases of RV dysfunction. And cardiac output may increase in case of prone responsiveness if the prone position-induced increase in intra-abdominal pressure is not excessive. So again, you can look at this recent paper to know more about the effects of prone position on hemodynamics. Thank you very much.